Hello everyone, today's topic is hemorrhage and we shall be discussing about the various classification definition of the hemorrhage. Hemorrhage is defined as a means of escape of blood outside its containing vessels, that is the artery and the vessels and the veins and the capillaries. So based on the classification, it can be classified depending on the nature of the vessels involved, depending on the timing of the hemorrhage, depending on the duration of hemorrhage, and depending on the nature of bleeding and the type of interventions. So first is the source, that is the arterial source. The arterial hemorrhage will be bright red, emitted as spurting jet, and can lead to severe blood loss, and often it is hard to control, and the hemorrhage is pulsatile. Or then the venous hemorrhage or venous bleeding, it is darker red in color, and steady and copious flow of the blood is seen. Color becomes further darker with oxygen desaturation, and usually it is easy to control. Then capillary bleeding can be seen, which is as can be seen as bright red in color, rapid and oozing. Blood loss becomes serious if continuous for hours, and it is generally minor bleed and can be controlled very easily. Then based on the timings, then the hemorrhage can be primary hemorrhage. It occurs at the time of surgery, and the cause is injury to the vessel. It may be arterial, venous, or capillary, and more common in surgery on malignancies. Then reactionary bleeding or reactionary hemorrhage, which occurs within 24 hours, usually 4 to 6 hours of surgery, and the cause is slipping of ligature, dislodgement of clot, or cessation of reflex vasospasm. The bleed starts when there is a rise in the arterial or venous pressure. Then secondary hemorrhage, it occurs after 7 to 14 days of surgeries, and the cause is sloughing of the vessels due to infection, pressure, necrosis, or malignancy. First warning is the stain followed by a sudden severe bleed, and it is common after hemorrhoid surgery, GI surgery, and amputations. Then, according to the duration, the hemorrhage can be acute hemorrhage or chronic hemorrhage. Acute hemorrhage is which occurs suddenly, and example esophageal visceral bleed due to portal hypertension, or chronic hemorrhage, which is the continuous slow bleed. Then, on basis of nature or type, external hemorrhage or the hemorrhage or bleeding which is revealed, external or visible bleed of soft tissue injuries or bleeding from the limb vessels and wounds or nose, and internal hemorrhage or hemorrhage which is concealed, the internal or invisible bleed which results into blunt or penetrating trauma may remain concealed as it ruptures spleen or liver, and concealed hemorrhage may become revealed as in hematemesis or a melanoma in peptic ulcer. Then based on type of intervention, surgical hemorrhage is the result of injury and amenable to surgical control or from angioembolism, and not surgical hemorrhage is general ooze from all raw surfaces due to coagulopathy. It cannot be stopped by surgical means, requires correction of the coagulation abnormalities. Then pathophysiology of hemorrhage, the bleeding will occur, that is the loss of the blood from its containing vessel, which will result into hypovolemia, which will in turn cause hypoperfusion and accumulation of the lactic acid, causing lactic acidosis, along with cellular anaerobic metabolism, which result in coagulation proteases and coagulopathy, and it will result in increased ischemic cells and anticoagulation pathway, which will result in decreased tissue perfusion, and there will be followed by early compensation, which is the early compensatory process, and the unperfused muscles are unable to generate heat, which will result in hypothermia, and this will result into hypoperfusion and acidosis, and if not controlled in time, will result the patient will die. The clinical features are pallor, thirst and cyanosis, tachycardia, tachypnea, cold, clammy skin due to vasoconstriction, dry face, dry mouth, and loose skin appearance due to contraction of erector pylori. Rapid thready pulse or hypotension may be seen, and oliguria may be seen. And the features related to specific cause can also be seen. The degree of hemorrhage can be divided based on the degree of hemorrhage or the amount of blood loss. The first type is the blood loss is less than 15%. The second type is the blood loss is between 15 to 30% of the total blood volume. And the third type is the blood volume loss between 30 to 40%. And fourth is the blood loss volume is greater than 40%. Now coming to the measurement of blood loss, the normal blood volume, which is 5 liter to 5 to 8 liter, is estimated as 70 ml per kg in children and adults, and in children and adults, and 80 ml kg for neonates. Estimation is difficult and inaccurate, and OT blood in suction apparatus can be measured, and the swabs soaked in blood can be weighed in order to measure the blood loss in the OTs, and hemoglobin is evaluated, and PCV is estimated. The management concepts include identifying of the bleeding vessel and hypovolemia and shock clinically, resuscitation of oxygen and blood and fluids, identify the site of hemorrhage, ultrasonography or endoscopy can be used along with CT scan, and DPL and blood tools can be done for identifying the site of the hemorrhage, and control of hemorrhage can be done through surgical procedures or through cautery or through endoscopic control or through diabetic embolization. Then definitive treatment may be necessary in few cases where there is excessive hemorrhage. Sepsis control should be done, prevention of coagulopathy should be done, critical care management is to be done, and endpoint resuscitation, fluid and electrolyte management, and prevention of organ failure should be considered. So I will end this lecture by saying that when there is a blood loss, replace it with blood. Although other fluids can also be used, such as plasma expanders, the colloids and colloids can be used, but when there is a blood loss, it should be replaced with blood, which is the best alternative. So in order to stop hemorrhage, first thing is to apply direct pressure with gloved hand and sterile dressing. If there is stoppage in bleeding, then treat for the shock or care for the wound, then seek definitive treatment. If the bleeding does not stop after applying direct pressure, then elevate the extremity or the part where there is the bleeding is occurring from above the heart of the patient, and keep applying the direct pressure. If the bleeding stops, then go for the caring of the wound or seek definitive treatment. If the bleeding does not stops after elevation of the extremities, then locate the pressure point and apply pressure at that point, along with applying direct pressure over the wound. Even in that case, if the bleeding does not stop, then you should see that if that bleeding is from the extremity. If the bleeding is not from the extremity, then go for a definitive treatment. If the bleeding is from the extremity, then apply a tourniquet, which is the last resort, and probably after applying a tourniquet, the bleeding should stop. So this was all about hemorrhage. Thank you.